Hello everyone, this is Miss Davis. I am going to be doing the lecture on loss, grief, and dying. Okay, so what is loss? This is an undesired change or removal of a valued object, person, situation. So many of us have experienced some sort of loss, even if it's just in the loss of a pet or a family member, a loss of a job. There's a lot of different things that can be lost that can affect you. So we're going to talk about a few different kinds of loss. So there's actual loss. This is the death of a loved one, the end of a relationship, a natural disaster, any of those kind of things. Loss can be identified by others, not just the person experiencing it. A perceived loss is internal. It's only identified by the person experiencing it. So there's different ways to think about perceived loss. Some people, maybe a big one might be, sorry about that. A perceived loss could
be something that somebody thought they had and now they've lost that. So I'm trying to give you a good example. I would say maybe I'm thinking about okay, that one really stumped me, so I had to look it up. So a perceived loss, maybe I thought I was going to college, was prepared to do that, and something happened financially, something happened in my family. I can no longer do that right away or when I need to. So that's something where I feel a loss. I have to grieve that. A physical loss either includes an injury, so maybe an amputation. I've had a surgery, an organ removal like a hysterectomy. Maybe I've lost use of my legs and now I'm paralyzed. So those are physical loss. A psychological loss is usually seen more in a loss of control, fairness, meaning, and trust. So this could also be a loss of youth, a body disfigurement. Maybe I was in an accident and I don't look the same as I used to. My body function is not the same as it used to be. So they're losing their dreams. They're planning for the future. External losses are actual losses of objects with sentimental or monetary value. So maybe someone has broken into my home and I've lost jewelry that my mother gave me. It's an external loss. An environmental loss is something that changes in the familiar. So even if the change is perceived, so I'm moving to a new home, I'm getting a new job, a change from high school to college, those are all considered environmental losses. And then loss of a significant relationship. That includes spouses, siblings, family members. This can be through death, divorce, separation. Something has happened to cause this loss. So let's look at this question. The student nurse has earned A's in all of her prerequisite courses. For the first exam in a nursing course, she earns a D and now feels that she may not be smart enough to become a nurse. What type of loss is the student experiencing? I know none of you can relate to this question. So our answer is going to be D. It's a perceived loss, as she is perceiving that she's not smart. That's an internal thought process. It's not a physical loss. So what is grief?
Grief is a physical, psychological, and spiritual response to mourning. To a loss. Mourning is that actual process that we go through, the action that's associated with grief. Bereavement has more to do with mourning and adjustment time following a loss. So there's all kinds of theoretical foundations of grief. The big one that we deal with mostly in nursing, we use Kubler-Ross. All these are important, and it's going to depend on where you're at, what you're going to use. But you're going to see the Kubler-Ross the most, so that's the one we're going to talk about a little bit. She has 5 stages of grieving. Individuals may not experience every stage or go through the stages in a linear order. What do I mean by the word linear? So they don't go in a straight line. So in addition, individuals may experience 2 or more stages simultaneously. So just understand that all these are different theories of how people grieve. So what kind of things affect grief? So the significance of the loss. So it depends on what has been lost, how significant that is to a person. Is it an object? Is it a living person? The more that you are attached to something, the more difficult the grieving is. I think in that as well, sometimes thinking about young children, if they are attached to something, maybe it's a pacifier, a blanket, a stuffed animal, you lose that, and then the parents go on this frenzy of trying to find what happened to it, because this is becomes something that their child is very attached to. So that's a thought. Support systems, so the amount of support for the bereaved. People with more emotional and psychological support typically have less complicated grief. Not grief, but complicated grief. Unresolved conflict. So maybe someone has passed away and we still, myself and this person still had some unresolved issues. We had an argument, and this person left very quickly, was in a car accident, and passed away from his injuries. That's something that's not resolved. So this may prolong grief. And then the circumstances of the loss. Did the person have time to grieve? Was this a diagnosis of a medical disorder? So I have had the last few months to kind of come to terms with this is what's going to happen. Was it a sudden loss? Was it an older person? Was it a younger person? Those things are all going to affect grief. Previous loss. So how many other losses have this person had in a short period of time? So I know when my mother-in-law and father-in-law lost their youngest son, she also lost several of her very close best friends within pretty close succession of each other, and that is very hard to deal with because you just feel like you can't get back out of that grieving spiral. So that's something to think about. Their spiritual and cultural beliefs. So we've been talking about spiritual and cultural beliefs, and we talked about different cultures, different religions. So if I don't have a great support system in that way, that's going to be very difficult for me to recover from. I need to have some sort of spiritual belief that helps this grieving process. Typically there's some sort of a ritual, like a funeral, a wake, something that the family can use to help grieve. Some cultures may be more stoic and not show their emotions and be very subdued. So that's something to think about. Timeliness of death. So the death of a child or a young person is really much harder to deal with than that of someone who's older and had a full life. In general, those who suffer a sudden loss typically have a more difficult grieving than those who have had time to prepare. So I hope that makes sense. If I've had time, if I knew that this person was sick, we had a timetable of a couple months, of a year, that's a bit easier to deal with than those people that are in an accident and suddenly gone. In addition to loss of the person, there's a sense of unfairness because the loss of a potential. So if I lose a child, then I think about not only losing that child, but what else could this child have been? What could have happened? What could this child have done in the future? They could have got married, had children. So you also grieve that whole stage. So you might hear a lot of, why was this person's life cut short? The developmental stage of the bereaved is also going to be something to think about. So if the person that's grieving is a child, they're going to grieve differently than that of an adult. So depending on their level of development, where they're at in that stage of life, it will depend on how well they do with grieving. So there's some different types of grief. Okay, so uncomplicated grieving is usually, that's normal grief. That's a response to a loss. The bereaved person experiences those feelings, behaviors, and cognitions that are expected. The emotions are intense but gradually diminish over time, usually over several months to several years. Some emotions will always be present, but the intensity will change. Now, talking about complicated grief, this is distinguished from uncomplicated grief because it's a more lengthy amount of time. Also, the intensity of the emotions are more intense. The person responses of grief are maladaptive and dysfunctional. Usually they're prolonged or overwhelming. Complicated grief results in the grieving process has been impeded for some reason. So this person is just stuck in grief process. So chronic begins as a normal grief, but it continues long term with little resolution of feelings and inability to rejoin normal life. Masked grief occurs when the person is grieving, but the expressing the grief through other types of behavior. So maybe as a child they're acting out in class or being mean to their family members. Delayed is grief that is put off until a later time. I'll think about it later. Right now I'm busy trying to keep a roof over my head for my children, so I can't grieve for this, whatever it is. Disenfranchised grief is experienced in connection with a loss that's not socially supported or acknowledged by the usual rites or ceremonies. This can be experienced by a man whose wife who's had a miscarriage, a mistress whose lover died, a bereaved partner in a homosexual relationship not recognized by the families. So maybe I'm unable to grieve. Anticipatory grief is more of what we've been talking about with patients that know that they're going to die, that there's a limit to their time. They have a time clock running. So sometimes the survivor might start to detach from them just to maintain their own feelings. So, young woman's fiance died in a car accident 1 month prior to the wedding day. Since his death, she's become sexually promiscuous. What type of grief, if any, is this woman displaying? So really she's got some masked grief going on there, right? 'Cause she's it's maladaptive. She's expressing her grief through going out and having sex with multiple people. So that is a masked grief. So how do we define death? So there's higher brain death. That's where the brainstem can still be functioning. So we know if our brainstem is functioning, we have which parts still working. Our respiratory and cardiac. So they may not have any other activity going on. There may be no other brain activity, but they're able enough to have that brain function still control the respiratory and cardiac functions. So the Uniform Law of Commission is defined death as an irreversible cessation of all functioning of the brain, including the brainstem. So this definition did not provide clear guidance for the United States for us to know what is actually brain death. So they came up with the Uniform Determination Act, Death Act. This was adopted in 1981 to try to clarify and explain the meaning of death. Providers use several methods to assess for functioning of the brainstem. They look for fixed pupils, unresponsive to light, no corneal reflex, absence of vestibular ocular reflexes. Coma and a persistent vegetative state. Coma is a prolonged deep state of unconsciousness lasting days or even years. The patient cannot be aroused and may or may not have decreased brainstem reflexes. They can have, if they have loss of higher cerebral functions, that can result in a persistent vegetative state. And this person does not purposefully respond to stimuli, is unaware of the environment, has no cognition or effective mental functions. So the physiological stages of dying. So 1 to 3 months prior to death, the dying person begins to withdraw from the world and people. They're going to increase their sleep. They're probably not digesting food very well. Appetite and food intake decrease. Typically are on a liquid diet. They may have some anorexia. They may end up being in ketosis, and that can diminish pain and increase the person's sense of well-being. 1 to 2 weeks prior to death is a host of physical changes that indicate the body is beginning to lose its ability to maintain itself. And then days to hours prior to death, there's often a surge of energy, bringing mental clarity and a desire to eat and talk with family. However, as death approaches, patients tend to become dehydrated and have difficulty swallowing, which decreases blood volume. In the final hours of life, many patients become restless and agitated. This response may be caused by medications, liver failure, cerebral hypoxia, renal failure, stool impaction, distended bladder, increased pain. Near to the time of death, some people unexpectedly become more coherent and energized for a time. Others become less communicative, quiet, and withdrawn. Moments prior to death, the dying person does not respond to touch or sound and cannot be awakened. Typically, there's a short series of long-spaced breaths before breathing ceases entirely and the heart stops beating. Asystole is a dysrhythmia that serves as a confirmation of death. It is the absence of an apical pulse, so asystole. End-of-life care. So there's a couple different things. Palliative care is something that's aggressively planned. It's usually some sort of comfort care. General issues for most of your end-of-life patients include, we want to make sure we're supporting families and caregivers. We want a continuity of care. We're going to respect all of the people that are involved. Make sure your patient's making informed decisions. Attend to emotional and spiritual concerns. Support function and survival duration. Manage the symptoms. So pain, dyspnea, depression, these are most important goals of of palliative care. We don't want them to suffer. And then there's hospice care. So the hospice care is based on two key premises. The quality of life is as important as the length of life. And number two, those who are terminally ill should be allowed to face death with dignity and surrounded by the comfort of their home and family. So hospice providers consider helping family members an essential part of their role. Legal and ethical considerations. So advance directives, these are a group of written instructions, they can be oral but mostly written, stating a person's wishes regarding his or her health care if he or she were incapacitated or unable to make that decision. So, again, advance directives is some sort of instructions, written or oral, where the patient tells us what they want done, what their wishes are, who is their health care surrogate to make those decisions for them. It's an ordinary power of attorney, does not give another person the right to make health care decisions for the patient, only a durable power of attorney. A DNR or a A&D, allow natural death, is in order to not attempt resuscitation of the patient in the event of a cardiac or respiratory failure. Assisted suicide means making available that medication that's needed for the patient to end his or her own life. The patient's physically capable of ending his or her own life, has expressed the intention to do so, and has turned to the healthcare provider merely to supply the means. So the ANA prohibits nurses' participation in assisted suicide and euthanasia because these acts are in direct violation of the nurse's ethical traditions and goals of the profession and its covenant with the society. Nurses have an obligation to provide humane, comprehensive, and compassionate care that respects the rights of patients but upholds the standards of the profession in the presence of chronic debilitating illness and end of life. So that's a statement from the ANA on that. Okay. Euthanasia refers to the deliberate ending of a life of someone suffering from a terminal or incurable illness. So active euthanasia occurs as a result of a direct action, so giving an overdose of a medication, where passive euthanasia occurs as a result of a lack of action. So I'm withholding medications or food. An autopsy is a medical examination of the body that determines the cause of death. They also give us relevant data about the disease process, and it has to be signed, and unless it's required by law, then that's something that has to be paid for by the family. And it can be very expensive. Organ donation is something that we would like everybody that can donate to donate, because it can save many other lives. So, assessment for a terminally ill client and his family. So, in addition to the items listed on the slide, the following 3 assessments can be done for the dying client. When the client and family are ready, encourage them to talk about the client's wishes for burial or cremation. Do they have an advance directive? We need to talk with the family about the possibility of organ donation. Depression or grief. Although grief and depression have common symptoms, sadness, insomnia, weight loss, grief tends to come and go, to be triggered, for example, by a holiday. Diagnosis for terminally ill client and family. So sometimes we have a diagnosis of a terminal illness. So what are we going to do with that? So situational or chronic low self-esteem relate to inability to change the event for self or significant other while related to dying. And they have unfinished business. Anxiety related to possible inability to cope with a loss. Death anxiety is just a fear of death. decisional conflict related to the end-of-life treatment measures. They can have deficient knowledge related to the new experience of caring, and fatigue, as well as spiritual distress. So some of our plannings and outcomes, the big thing is we want to communicate openly. We want to make sure we're definitely dealing with pain. Anything that we can do to help with coping is a big deal. The family, we want to make sure that there's some sort of grief counseling involved if needed, and keeping the family involved with what's going on with their family member. So therapeutic communication. So we've talked a lot about communication and how to do that. So we want to make sure that when we're doing this, that we're really open to talking to the patient, listening to the patient, letting them talk, using touch, all those things that we've discussed several times in the last few weeks. So how do we facilitate grief? So we do that by encouraging questions, having them respond, sit by the head of the bed, don't make the patient feel like you're rushing, give verbal and nonverbal cues that you're listening, ask questions like, how would you like me to help? What do you need? What can I do? Be sure that the healthcare team understands. Talk to the patient and avoid things like, I know how you feel, unless you have been in a dying situation, you probably don't know how they feel, or instead you could say, tell me how you feel. Recalling memories is really important, so allowing that to happen and encouraging the family to do that. Finding meaning, so it's important for patients that they have a chance to talk and review their life. So pictures and other things would be really important. Then there's bibliotherapy. This is counseling that's used for grief therapy. It's a guided reading using poems, novels, essays, other things to help walk your patient through that those last days. Helping families of dying clients. So there's a lot of things that we can do, but the biggest thing is just be available. Anticipate that they are going to need some guidance, and acknowledge that they're grieving. Be kind. That's always a big thing. The final stage of death can last days to hours. This is important for the family who wants to be present at the time of death to know. It's important information to provide to the family so that an informed decision can be made about leaving the patient's bedside. Don't keep promises you can't keep. So don't tell them that, you'll sit with this patient until they get back if you can't sit with that patient till they get back. So we have a 55-year-old patient that was just informed that she has metastatic pancreatic cancer and has 4 months to live. After the provider leaves, she says to you, I don't want my family to know, but they have to know. Please don't tell them. Please tell me what to do. Help me. What's your best response here? I know this is difficult for you. Take time to think about it. You should get a second opinion before you alarm your family. Let me hold your hand and make you feel better. Or that letter D, tell me how you're feeling right now. So the best thing is, tell me how you're feeling. Let's talk about this. So care of the dying person. We've got to meet those physiological needs. So that may mean oxygen, nutrition, fluids, personal hygiene, control of pain. Psychologically, we need to meet with allowing these patients to meet with their families and try to visit. We'll address spiritual needs, like if they were very active in their church or not so active in their church. They may would like someone to come and talk with them. And then cultural needs. What are important for your your culture, yourself, in this process of actually dying. So the client's dying of cancer and can no longer swallow. The son states to the nurse, "You must give Dad some water. He always drank a lot of water." The nurse's best response is, "You sound very upset. Tell me more about your dad." "Your father's dying from cancer, and water will not stop this process. Research shows that withholding oral fluids decreases edema. I will call the provider and get a prescription to insert an NG tube for the water." So A is clearly our best answer. We want to do what is the most therapeutic. Providing post-mortem care, that's just caring for the body after death, making sure that we're calling transport to the morgue or funeral home, getting the patient cleaned up so their family can come in and visit with them one last time. Those are things that are really important. After death, we want to give some education and provide support to the grieving person. They may be fatigued or tired, so decisions may not need to be made right away. We can reassure them that there's no single right way to grieve. Everybody grieves differently. So some of the hardest is dealing with children with loss because they don't have any life experience. They're not really sure of what's happening with this. So trying to answer questions as much as you can in a very tactful manner is very important. So it's very normal for the nurse to feel grief when a client dies. You also have to take care of yourself. So sometimes you may need to take a moment and step out, away, take a break, get a few minutes to clear your head. If this is someone that you've taken care of for a very long time, of course you're going to grieve. That's a normal process. Just don't be over grieving in front of the family where they have to take care of you instead of you taking care of them. Okay, and lastly, Bob and Kim were walking with their 5-year-old twins when a driver lost control of his car and hit them. Both girls were rushed to the hospital where one was pronounced dead on arrival. The other twin suffered several broken bones and was listed in stable condition. She keeps asking for her sister. What factors should be considered in this scenario? First of all, wow, okay, so what do we even do? We're going to try to answer things as best we can. You're going to have to defer to the parents in this situation just because what their spiritual and cultural responses to death is what they're going to want. So I kind of defer to the parents in that respect. There's going to be a lot of issues, so maybe getting some sort of grief support in is going to be really important for them. Everybody, of course, grieves differently, so these are all things that you might have to discuss with them. And then they may actually need to seek out specialized counseling for the child, because not only was she in an accident where she was just innocently walking on the street, now I've lost my twin sister as well. So that's a lot of trauma for a patient to incur. I know that was such an uplifting lecture. I apologize, but it is part of our job, one of those things that we do. So please email me if you have any questions or meet me after class. Thanks.